Good evening, everyone, and welcome to another session of Intellectus Campus. I am going to be introducing Dr. Erika Drewes. We have pre-recorded this session, which you will notice because when the recording starts playing, I'll be wearing something completely different. So it's a bit hard to hide it. And Obi was supposed to introduce Erika, but he's a bit stuck at the moment with no connection in Botswana. So I am having some fun at the moment with IT, and my team know exactly how good I am at technology, which is not very. So I will be introducing Erika, and I'll then be showing you a couple of slides, but some housekeeping. Please stay on mute unless the host invites you to speak. Look at the chat for the attendance register. And if you are having problems with hearing this, I've put the slide on because quite often people have not connected to audio. So as I go, Pride, can you please confirm you can hear me?
Loud and clear.
Wonderful. So I'm going to introduce Dr. Erika Drewes and give you her bio, which is already on the group. Dr. Erika Drewes is a highly experienced specialist family physician with 2 decades of practice in both South Africa and the United Kingdom. After earning her medical degree, she worked in various private and public hospitals across Gauteng, KwaZulu-Natal, and the UK. She holds a master's in family medicine from the University of KwaZulu-Natal and a diploma in obstetrics from the Colleges of Medicine, South Africa. Currently, she is pursuing the fellowship in anti-aging and metabolic medicine through FAAMM, and she demonstrates a commitment to continuous learning. Her professional interests encompass women's health, hormonal balance, connective tissue health, rehabilitation, gut health, mold illness, autoimmune disease, chronic fatigue, and chronic infections. In addition, she is an active member of the South African Association of Integrative Medicine, also known as SASIM, and the International Lyme and Associated Diseases Society, and is enthusiastic about meeting individuals. She is dedicated to assisting patients and doctors on their health journeys. So I would like to welcome Erika. And before I go into the Erika's presentation, which, as I said, is pre-recorded, I'd like to just quickly cover a couple of basics on hormone balance and what is new in women's health, because Erika has assumed a level of knowledge that all of us may not have. So the first thing in terms of Mythbusters is that HRT is not just one umbrella. HRT contains estrogens and then progesterone, but progestins are synthetic progesterone and they act completely differently to bioidentical progesterone. So what has come out of the Women's Health Initiative is that progestins, particularly MPA, are associated with breast cancer. Synthetic progestins are also the culprit in high cortisols, central weight gain, and acne, as I'm sure many of us have experienced when we have given a patient depot or an implant. Estrogens do not cause breast cancer and may actually be protective, with estradiol, which is E2, but estradiol is the most potent, and many of you will know that as Femigel. One of the other concepts that's important to understand is what is estrogen dominance, because it's more about the ratio than it is about the absolute numbers. So at the age of about 35, a woman will rapidly drop progesterone because she stops ovulating every cycle. And when estrogen is high and progesterone is low, you have a high estrogen to progesterone ratio. It also coincides with a high estrogen to testosterone ratio because testosterone follows a very similar curve to progesterone. So estrogen dominance, which is low progesterone and low testosterone compared to estrogen, results in mood swings, depression, low libido, fatigue, foggy thinking, premenstrual syndrome or continual cycle irritability syndrome, irregular menstrual cycles, very heavy bleeding, thyroid dysfunction, fibroids, endometriosis, breast tenderness, and fibroadenomatosis. So I think anybody who has dealt with women who are coming up to menopause will recognize many of these things, and we treat many of these patients with progestins. So we give them 10 days or 5 days of synthetic progestins to delay their cycle, and we wonder why they get worse. We also quite often put these patients on antidepressants, and we start trying to manage their thyroid and send them for surgery for their fibroids, when in actual fact, progesterone to restore the balance in the second half of the cycle might sort them out. We also want to address in this talk low testosterone in women. Most labs will only report a high testosterone, which is associated with polycystic ovarian syndrome and various other disorders. But low testosterone is very important, and women produce 10 times the testosterone that they do estrogen. However, the ratio in men is very, very much higher. Women need testosterone to make estrogen and progesterone. So low testosterone in women is a real problem, and it also starts declining, and it declines particularly fast from the age of 35. So, and in some women it's earlier. So what are the symptoms? Fatigue, exhaustion, disturbed sleep. When a woman comes in complaining that she cannot sleep, she can go to sleep and the night in anxiety, you need to suspect that her testosterone is dropping and her estrogen levels are high and she's premenopausal, because this is very, very easily managed, particularly with a compounding pharmacy. The weight gain that comes in perimenopause, the mood swings, the depression, and the anxiety may be a hormonal disturbance, for which putting on a Band-Aid, which is something like citalopram, does not always help, because all of the SSRIs stop the production of melatonin, so you will actually make sleep worse. So I hope this gives you a little bit of an insight. Just to remind you about the housekeeping, please stay on mute. And at this point, Pride, I'd like you to start the video. I will stop sharing. Good evening, everyone, and welcome to another session of Intellectus Campus. And thank you, Obi, for that introduction on Erika. Erika is no stranger to this platform, and her last talk was on chronic fatigue syndrome and has been extremely well received by many patients and by many doctors who treat chronic fatigue. So on the group tomorrow, I will share that specific YouTube clip along with today's talk. But as we know, the Women's Health Initiative study caused absolute panic. And I remember where I was when they declared that hormone replacement therapy causes cancer. And it's my understanding that there has been a complete turnaround, and things are infinitely more complex than we were originally led to believe, with synthetic estrogens and progestins, which are things like MPA and ethinyl estradiol. They are very, very different to those which are identical to our bodies. And many of those are made by the pharmaceutical industry, including Femugel and Utrogestin. So we look forward to the updates on that. And we also look forward to the new testosterone guidelines, because women make estrogen out of testosterone. And women do have testosterone. They actually have twice as much testosterone as they do estrogen. But it's often forgotten in the workup for women. And the fact that we only have 1/20th of the male doses does not mean it's an important hormone for us. So I'm very much looking forward to this presentation. And Erika, I'm handing the floor over to you.
Thank you very much, Jackie, also for that wonderful overview. It's exactly what you've just said. I'm going to be focusing a bit on the details, the updates, things that are new in hormone replacement therapy. And it is a huge privilege for me to talk to so many colleagues in Southern Africa. I feel like we all share the same burdens and problems. And when you see females in menopause, I hope that this guideline will inspire you to go the extra mile and to not just treat symptoms, but to actually connect with the deeper root causes of what these women are struggling with, and to actually reach for that prescription pad and prescribe what you have on order, because the whole point of the talk tonight is to actually equip you so that you can work with what you've got. And it's not going to be about use this and don't use that. So I really wanted to make it so that whatever you have access to, that you know what the wisest decision would be in that moment. So like Jackie said, I am a functional integrative doctor. That's the current focus of my practice. But my previous life, I worked as a family doctor, lots of HIV medicine in a public hospital. I've got a master's in family medicine. And I also did a diploma in obstetrics and gynecology. And I've always been very, very passionate about women's health and gynecology. And then I also want to note that I don't have any conflicts to declare regarding this talk today. Okay, now my slide needs to move on. Sorry. Okay. So I'm just going to outline the different aspects of the talk, just so you know where we're going. We will talk a little bit about the latest guidelines. As you know, there are many guidelines out there, and I basically collated most of them based on their most recent findings. And then I'm going to go straight into estrogen replacement options. We're going to talk about estrogen replacement and cancer risk. Then we're going to talk about progesterone. And then we are going to end off by talking about testosterone. I've not included adrenal fatigue and hormones like DHEA in this talk, because I feel that is a topic on its own. I just wanted to focus on the menopause hormone treatment. So some people talk about hormone replacement therapy, HRT, but I see in the newest guidelines, people are using MHT, which is menopause hormone treatment. And so I think the two terms are rather interchangeable. I think throughout the talk, I've tried to keep it to MHT, but I think sometimes I also used HRT, but that's what I mean. So this is, like I said, a summarized version of what most of the consensus statements are. British Menopause Society, North American Menopause Society, International Menopause Society, and the South African Menopause Society are what I looked at. But of course, there are many others, like the Australian Menopause Society, etc. They tend to release guidelines every four years or so. And I think the latest guidelines that I've seen from South Africa were around 2018. So at the moment, they still suggest that all products that are out there and registered should be used, and they basically punt synthetic hormones at the same level as bioidentical hormones. And there is good evidence for some of that recommendation, and not so much good evidence for the progestin side of it. But I'm going to go through that with you. then where hormone replacement therapy is contraindicated, for example, your breast cancer patient, you are advised to try something like SSRI or a noradrenaline reuptake inhibitor, and you could even try as a third-line gabapentin. Although I know that patients don't really like using this, and what's really interesting, new research that's happening is people are looking into phytoestrogens like lignans and extracts from aloe vera and various other plant substances that on the one hand stimulate the estrogen receptor and deals with the vasomotor symptoms of menopause, but it's got this inhibitory effect on the SERM receptor, which is anti-proliferative. So at the same time, it has this tamoxifen-like effect. And that's very exciting research that I think we should keep our eye on. They haven't made it into the guidelines, obviously, because there's still a lot of research that has to happen. But I'd be quite excited to see plant molecules instead of synthetic molecules as alternative on this guideline, hopefully in the next 20 years. Then we know that hormone replacement therapy is good for many things. So, for example, it prevents bone loss in postmenopausal women. And I think what I really want to highlight here is that we have this guideline that within 10 years of menopause, so if you see a woman and she's not yet 60 and she has got early onset osteopenia, it's not too late for her to start on hormone replacement therapy. You can definitely initiate her, and they need to be younger than 60. But in the event of osteoporosis, if a patient is over 60, you can consider starting this patient late on hormone replacement therapy as a second-line treatment, because remember, these women are quite desperate to reverse osteoporosis. And actually, when you put the right things in place, year on year, it's a very slow process. But if you get the calcium, magnesium, hormone balance and inflammation right, you can get considerable improvement in the bone density scans. So do remember that it can be a second line option in women over 60. The reason there's these cutoffs of 10 years, within 10 years and 60 is that's what's been borne out by the randomized controlled trials. There seems to be slightly elevated risk of cardiovascular incidents if you start the HRT later than 10 years post-menopause. And the same thing for the 60s, and there seems to be not so much benefit. I think there was at some point also some indicators around cancer, but I don't think they are as clear either. Then we know that hormone replacement therapy reduces the risk of myocardial infarction. We know that oral hormone replacement therapy, especially oral estrogen, has been associated with the risk of venous thromboembolus, although the absolute risk increase is not really that compelling, they say, in this guideline, but in other observational studies that I'll show you, it is something to consider. And now the big change is that the induced breast cancer incidence of hormone replacement therapy is exceedingly rare, with less than 1 case per 1,000 per year of use. So that is similar or lower than the increased risk associated with alcohol consumption, obesity, or sedentary lifestyle. So we really can put people's mind at ease around hormone replacement therapy. And when we're talking about breast cancer, it is actually in the guidelines that when these second-line treatments like your SSRIs and your noradrenalines, etc., fail, you can, in consultation with the oncologist and with the patient, consider reintroducing the hormone replacement therapy. I know that it is done, but in very rare cases. Then there is weak evidence that it could protect against dementia and cognitive decline. And the other thing to remember is that there isn't a cutoff. There used to be a cutoff of 4 or 5 years, but in the latest guidelines, it is to be used for as long as a woman needs it. So it needs to align with what your clinical goal is and what you're trying to achieve. There are women who are very happy to do a trial after 5 years and see if they come off, if their hot flushes start up again and they don't like being on the hormones. And then there are other women that are maybe 80 and you bring them off their hormone replacement and they go back to hot flushes. So you need to take everything into consideration: cardiovascular disease, cognitive health, bone health, and before you make a decision on continuing or discontinuing. And then in terms of the gynecological guidelines, testosterone replacement is supported for women with sexual interest arousal disorder, which basically means, you know, reduced libido and reduced pleasure and all of that. So there are some guidelines on that I'm going to go through a little bit later. And then, of course, the guidelines all strongly recommend against the use of compounded hormones. And I'll say a little bit about that also later. That was the heaviest slide, I promise. Now we're going to go into the faster slides. So just talking about estrogen, what we know. So in terms of safety, the one principle you have to always remember is that the transdermal estrogen you actually can't go wrong with. Transdermal estrogen is much, much safer than oral replacement. Why? Because of the risk of venous thrombus and embolus. But if you're living in an area where on your essential drug list, all you can get is the conjugated equine estrogen, that is still better than nothing. So if you have a woman in early menopause and that's all you can get, you should consider using it. And I'll show you from the trial data that I've got that conjugated equine estrogen really reduces risks of many, many diseases. And I really do think that the benefits outweigh the risk. Then in terms of the efficacy, the bioidentical estrogen, we don't have a huge amount of data yet, but it is definitely moving in this direction where you can see that the bioidentical has got quite a good efficacy and in some cases a better efficacy than your conjugated equine. But we don't have a lot of studies where synthetic estrogens are compared to bioidentical. So now I just want to talk to you a little bit about the products. So I've basically given you just the differences between conjugated equine estrogen and 17-beta estradiol. There's also other products like estradiol, hemidrate, etc. on the market, and also the LivyFem products. I have not really focused on them on this talk because I know that especially in the South African public sector, mostly the conjugated equine estrogens are still what's being used, and that's at a primary healthcare level, sometimes the only thing that's on script. And then what you can get at the pharmacy now, you've got these registered FDA-approved bioidenticals, which are made with 17-beta estradiol. So about the conjugated equine estrogen, it's a very old estrogen. You can see the structure of it, the premarin at the bottom of the picture, and you can see that the molecular structure is completely different to that of estradiol. And so the reason we use the word bioidentical is not because we're trying to tell people that it's natural, because these hormones are not natural. We're not going out and pulling a yam out of the ground and mashing it up and making estrogen. People think that. They come to you and they say, I want natural estrogen, but that's not what it is. It's very, very difficult to synthesize a product from a raw plant. Anybody who's had to, make a cannabis oil or a tincture will tell you that, because plant genetics differ and the strengths of products can differ, and you can't provide a scientific consistent dose like that. So what's happening is that we now have the technology whereby we can synthesize a bioidentical molecule in the laboratory. And because we can synthesize it now, we can put it into products. And the difference between that and something synthetic is that our body recognizes it. The body knows it. So the way that it's metabolized, the way that it binds on the receptor, and the way that it leaves the body is very identical to what our body's own hormones would be. And therefore, we will have a reduced risk of side effects. And you will see now when I talk about progestins, that's borne out very clearly from the research. So when we work with a 17-beta estradiol, we talk about the Femigel, which is the product that's registered in South Africa and I think also in the SADC region. But there's also the Clamora patch, and there's also an Estradot patch. The one is applied weekly and the other one is applied twice a week. The Clamora patch and the Estradot patch come in different strengths, so you're able to titrate how much you want to give the woman. And maybe one day I can come back and actually do a teaching on how to, how to approach those doses. But what I normally do is I try and assess, just broad strokes, how severe are the hot flushes. If a person is flushing, 20 times a day and she can't sleep at night, that woman is severely estrogen deficient. I also look at the FSH level, and if it's very, very high, then I know I need to go in with a mid to high range. I actually would go in with a high range dose in a patient like that. And if I have a patient where the flushes aren't that severe, she's maybe got a bit of sleep disturbance, maybe she's a bit more emotional, she's feeling a bit dry, but her flushes aren't excessive, maybe I will go with a mid-range dose. And if I have a patient that tells me that she could never take the pill, she's sensitive to hormones, but she is flushing, and she's maybe in early menopause, I might actually start off on one of the lower patches. But the other thing I might just highlight is that some patients do over time develop an allergy to the glue in the patches. So the FAAMM, which is the pump action one, works really well because that doesn't have the scenario of the glue. It's applied to the arm, and you can play with it a little bit in terms of the dose. I mean, the full recommended dose is 2 pumps a day. But if you have a woman who is very sensitive to the estrogen, you can recommend 1 pump a day. Sometimes they use the pump, twice a week. It just depends on where that patient is balanced together with her progesterone. Then just to come back to the conjugated equine estrogen, it is derived from pregnant horse urine. And so some people will tell you, well, it's a naturally occurring hormone and therefore it's a natural hormone and we should be using it. Yes, if you are a menopausal horse, but not if you are a woman. So I do disagree with that take. It is a very, very powerful estrogen. Binds quite strongly, and in women who are very sensitive to estrogen and to tend to become estrogen dominant quite quickly, they will react very, very strongly to this estrogen. They will immediately start becoming PMSy. They'll tell you that their breasts are swollen. They might have breakthrough periods. In that case, you might have to lower the dose and reduce how much you're giving that patient, or maybe just switch to the vaginal Premarin. It's very, very, yes.
I'm sorry to interrupt you, but I wanted to make this a little bit more interactive. Now, when I trained in this, I was told there were 3 kinds of estrogen: E1,
Yes.
2, and E3.
Yes.
And to try and get away from the bioidentical and equine and stuff, simply because those are kind of labeling names and they've become meaningless because of what mainstream media has done. So I was taught E1 is proliferative. E2 is our natural estrogen and it is potent and it does the job. And E3 is protective. So when doing bioidentical combinations, you can have an 80-20 E2, E3 in a low-risk patient and a 50-50 E2, E3 in a high-risk breast cancer patient. Is that kind of is that a decent summary of what you've just said?
Yes, yes. I didn't include the compounded hormones on this. I decided to just work with the registered products because I know that many colleagues don't have access to the compounded. But if some people do come in asking for compounded, and you're exactly right. We use what they call a bi-est, which is 2 kinds of estrogen, which is the E2 and the E3. And the E3 has been shown in vitro studies to have an anti-proliferative effect on the breast, whereas E2 is the E3 is anti-proliferative and the E2 is proliferative. So the idea is that if we give this together, then there'll be a balanced application. The only thing with that, Jackie, is that I really searched the literature to find good randomized controlled trials on this bi-est combination, and there are very few. And since this talk is also an evidence-based talk, I decided not to really focus on that. But I can come and do a talk on how integrative doctors do that, how we approach that. But it would be like that. It would be a 80-20 where you have 80% of the estriol and 20% of the estradiol if you're wanting a weaker solution. If you're wanting a mid-range, you might go with 60% estriol plus 40% estradiol. And if I use a 50-50, for me, that's the same as giving Femigel. I feel like they perform similarly when I give people that.
Great, thank you. I'll let you carry on.
Okay. All right. So now I'm going to talk a little bit about the breast cancer. And I just want to get onto my soapbox for 1 minute and say the following. If we remember, back in the day, there was a time that physicians actually, this is what they did. They recommended cigarettes because they thought they knew best and the data could get manipulated. And pharmaceutical companies these days do the same thing as what the cigarette companies did those days. So I think what I want to just say, I'm going to give you some of the information on the Women's Health Initiative and how things got botched with that thing and how it caused so much damage to so many women. The data collection for that study and the first one arm of that study got stopped in the early 2000s when a safety signal was detected that hormone replacement therapy was creating breast cancer incidence among the participants. And there's a lot of stuff that went wrong with that study, partly because the data set wasn't peer reviewed. It didn't go through peer review. It was just simply released to the press by the principal investigator. And then there were all sorts of problems with the study design. For example, women who were older were actually enrolled in the study. And the women who were in the placebo group who showed less breast cancer, many of them had actually taken hormone replacement when they were in their early menopausal years. And when they corrected for that several years later, when they took those women out, because we know that hormone replacement has got an ongoing protection. So even if you've only had it for 5 years, it has an ongoing protection. When you take those women out of the placebo group, you find that the placebo group had a higher incidence of breast cancer than the group of women who were in the placebo group but who had taken hormones. So they turned out to have protection from that early hormones. So there was a lot of disinformation and misinformation around that study, and it ended up in the last 20 years basically creating a huge amount of women who didn't have the heart disease protection, didn't have the osteoporosis protection, didn't have the hormone protection to the brain. I always say to patients, estrogen is your juicy hormone. It's what lubricates every joint in your body. So it keeps your skin nice and full. It helps with your eyes, prevent dry eyes. It keeps your mind sharp. It helps to keep you youthful and young. And those women were denied that opportunity of being healthy and actually slowing their aging. So what my lesson from that is don't just go with what the mainstream media and even the journals publish in the, as abstracts and things. Don't just read the abstract. Read the studies yourself and make yourself clever about data interpretation. Look at biases. Look at conflicts of interest. Look who the authors are and look who funds them, and stay up to date. And remember that many of the societies, even the societies who come up with the guidelines that I've just showed you, they are funded often by special interest groups, and it often interferes with their ability to make good calls in their guidelines. So remember that guidelines are there to help us, to guide us, but guidelines are guidelines. You still need to make a decision for the patient that sits in front of you, and you need to individualize. And then recommended reading. I don't know if anybody knows Peter Gotcha. He is one of the founding fathers of the Cochrane Review. He's got several books that he's published. And if you want to see how mainstream medicine gets it wrong and how the evidence can be manipulated, I really urge you to take a look at some of his works. So, okay, now I'll get off my soapbox. Okay, so let's get on to the breast cancer. So if we look at the updated findings, so what a lot of people don't know is that the Women's Health Initiative study was not concluded when that arm of the study was stopped. There was still another arm that continued. And when the study concluded in 2017, they had a 20-year study, and 98%, because remember, it was older women that enrolled, so 90% of the women's mortality data was already available to be interpreted. So they were able to study 27,347 postmenopausal women. They were between 50 and 79, and they needed to not have a previous breast cancer history to be enrolled. And the enrollment started between 1993 and 1998, and they were followed up in 2017. So in your first group, you had the conjugated equine estrogen versus placebo. So a conjugated equine estrogen only, so no progesterone, progestin. So unopposed estrogen versus placebo. And this is obviously in women who don't have a uterus, because that's the only place where you can give unopposed estrogen. Because remember, estrogen has got a proliferative effect on the lining of the womb. And we have to combine it with a progestin or a progesterone to balance out that proliferative effect so that women aren't put at risk of endometrial cancer. So in the second group, we had women who had an intact uterus, and they were given the combination of conjugated equine estrogen and a synthetic progestin called medroxyprogesterone acetate, MPA, and that was measured against placebo. So in our group 1, we had about 10,793 patients. And basically what we saw is that the conjugated equine estrogen alone group, you had only 2.2% of them went on to develop breast cancer versus 2.7% in the placebo. So that was a statistically significant finding. And in the overall mortality, the conjugated equine estrogen, we had only 30 deaths in the total cohort versus 46 deaths due to breast cancer in the placebo group. So you could see there that the conjugated equine estrogen significantly reduced the breast cancer incidence and death in this group. And if you have estrogen replacement, you'll basically not see so much breast cancer. And what the study also showed was that when women went on to develop breast cancer on hormones, they had less risk of dying. I think the relative risk was about 20% reduced of dying of breast cancer than if they had no hormone protection. Then in group 2, which is now conjugated equine estrogen plus medroxyprogesterone acetate. So this was the product that was causing the problem. So when we went back to the initial issue with the breast cancer, when they subdivided everything and broke everything down, the group that had the medroxyprogesterone acetate in it was the group that had the safety signal for the breast cancer. So medroxyprogesterone acetate is a synthetic progestin, and I will tell you about this next. We're going into progesterone next. But basically, this group had 3.5% of the women developing breast cancer versus 2.6% in the placebo group. So, and that was a p-value of 0.001, which is very statistically significant. And look, I mean, 3 and 2%, no, these are not big numbers. And some people have actually calculated it out. And it turns out that I think the total increase is another extra breast cancer per 1,000 patients, one extra case. So it's not dramatic in this study, but it was a slight increase there. So that's another reason why the guidelines changed and why they stopped recommending against hormone replacement, and they started putting the findings in context. So it definitely looked like the main driver was the synthetic progestin, and there was no significant difference in incidence of mortality. Okay, then I wanted to talk a little bit about the NIH study, which is the National Institutes of Health in the States. They're one of the biggest research facilities in the world and they've got the funding and the capacity to run really amazing studies. And this was a study called the 7 Million Women Study. And yes, it's an observational study, which is not supposed to be the highest level of evidence, but it's 7 million records that were identified, and that gives the study quite a lot of weight. The reason they could do it was a captured audience of patients, I think it's Medicare. They were on one medical aid, and they were being treated within a closed loop system where the hospitals and the GPs and the medication and everything was in one record. So it was very easy to see their journeys. Yes, it's Medicare. I see there on the slide, it was Medicare. Okay, so they were age 65 or older, and they were the analysis was between 2007 and 2019. So another 12 years of data. And they looked at the type of hormone replacement, the route of application, the strength, and they looked at various different patient outcomes, 13 different outcomes, including all-cause mortality, cancer, cardiovascular conditions, and dementia. And they looked at the records. If you look at the bottom there, I've given you the link, and I really recommend, it's quite a hefty read, but if you want to maybe go and examine that document, it's actually very interesting what they found. And there's a lot more in there than what I could put on the slide, and there's a lot more detail. So what, for me, some of the highlights that support the Women's Health Initiative study findings is that the estrogen monotherapy again showed a 20% relative risk reduction in mortality, with estradiol being more affected than conjugated estrogen. So here, the bioidentical estrogens seem to be more effective in reducing mortality than the conjugated equine estrogen. Even the vaginal administration had an effect on reducing mortality rate, which is something that's actually very nice to know. If you're treating a patient who can't take hormones, for example, a breast cancer patient, we know that we can still give them vaginal estrogen, and we know that vaginal estrogen will actually have an effect in reducing mortality. That I thought was very interesting. And then this reduction in mortality actually translated into the 77,401 fewer deaths in that population, which is, again, it's significant. We know now that the estrogen might help women live longer with an average of 5 years. Progestogens only did not reduce mortality. There was another finding, which is also consistent with the Women's Health Initiative finding. We also then, when we look at cancer risk, what I also found was really amazing was that hormone replacement therapy, estrogen therapy, was a reductive factor in various cancers, so including breast cancer, lung cancer, endometrial cancer, colorectal, and ovarian, so not just breast. And it was significant reduction for all cancer studies. So being on estrogen for at least 5 years decreased the risk of breast, ovarian, uterine, lung, and colorectal cancer. Sorry, I've put if you look at the bottom of the slide, I've actually given you the actual numbers, so you'll be able to calculate from there. The oral conjugated equine estrogen resulted in a greater risk reduction than transdermal in terms of cancer prevention. So exactly the opposite of the mortality. So here, the transdermal bioidenticals didn't perform as well as the oral conjugated equine estrogen. So I thought that was really interesting. And that's why I say to you, if you only have access to that, you really should use it. Progestogen significantly increased the risk for breast cancer. The risk of stroke was also slightly higher when women were on oral estrogen. And so here, this is where we run into trouble, is when we're having to use oral estrogens. So this is where you're going to have to make your risk versus benefit analysis with your patient and decide which route you're going to go with them. So now going into progestogens, what are the differences? So progestogen is an umbrella term. And in this umbrella term, we are including bioidentical progesterone, also known as P4, and synthetic progestins. And basically gynecologists do not make a distinction between the two, but actually the literature is starting to show us that there's a massive difference between the two in terms of how they behave in the body. And in terms of naturopaths and functional doctors, we definitely see the differences between the two. So it's produced from diosgenin. They synthesize it from there. And it's the only human progesterone that's on the market, and it's bioidentical, and our bodies know how to use it. Then we've got modified P4, which is this medroxyprogesterone acetate, with a very long half-life that's very potent, which is now a synthetic product. And then we've got the other types of progestins that are also synthesized from diosgenin, but synthesized obviously so that the molecule is more unique, so that you can patent it. And there are various potencies, various generations. I'm not going to go through them, but you'll know them from all of the hormone contraceptives that are on the market. They are in most of them. So I really recommend, if you want to learn more about this, and there's an excellent review article called The Pharmacodynamics and Safety of Progesterone by Piet, published in 2020. It is a fantastic review of how bioidentical progesterone behaves differently to the synthetic progestins. And the conclusion of this review article, after they look at all the different effects in terms of safety profile, how it behaves, the bioavailability, the biotransformation, the effects, and the various clinical applications, they make the conclusion that synthetic progestins do not share a class effect with P4 and affiliate molecules in terms of their safety and efficacy. So, for example, so what they're saying is P4 shouldn't be in the progestogen class. It's in a class of its own. It doesn't share the same molecular attributes, and behaves differently. So what makes it differently? So we've got now multiple studies at a randomized control trial level on natural P4. And by the way, the one that's probably most commonly on the market is Utrogestan, which is a gel cap that you can find in 100 milligram doses or 200 milligram doses. And it's used very widely for hormone replacement therapy, but it's also used very widely in terms of infertility treatment. It can be used orally. It can also, because the capsule is dissolvable, you can use it vaginally, which is similar to using something transdermally. And if you use something vaginally, you'll have a much more potent effect around the uterus and ovaries. So for example, if I have a woman with a fibroid and I want to give her progesterone, I might actually give her vaginal progesterone to help counter the estrogen dominance of the fibroid. So P4 plays an important role throughout a woman's lifestyle, from regulating effect of the menstrual cycle, conception, pregnancy, and birth. So we know, for example, that progesterone is very important to the corpus luteum, produces the progesterone in the early pregnancy, and only at week 13, when the placenta is mature enough, does it take over progesterone production. So a lot of women have a problem not producing enough progesterone in the first trimester, and then bioidentical progesterone is often used in that context to maintain the early pregnancy until the placenta is mature enough to take over the treatment, to take over the pregnancy. So P4 breaks down to allopregnenolone, the oral P4. So if I've got a woman who cannot sleep very well because of her menopause, I will prefer to give her an oral progesterone, because it breaks down to allopregnenolone, which has got a GABA-like effect on the brain. And it has a fantastic effect on insomnia. These women come to you and they can't sleep. And the minute you give them oral progesterone, they sleep like babies. And it really has a wonderful effect on calming down anxiety. So you mustn't just think when a woman can't sleep and she has anxiety that it's an estrogen deficiency. It's very often actually a need for more progesterone. And progesterone is also very neuroprotective, and that has been confirmed in many studies, and there are even studies in management of stroke, post-COVID, traumatic brain injury, where you've got overt neurological signs, where the P4 is being used as a treatment option for its neuroplastic and neurogenesis effects. Progestogens do not have this effect. Progestins also do not have the effect of calming the brain. Instead, you would see more anxiety on progestins. Natural progesterone binds to progesterone receptors and only weakly binds to glucocorticoid and mineralocorticoid and adrenogen receptors, or androgen receptors, which is why it has fewer side effects than the synthetic version. So it's the receptor binding is completely different. We also know that natural progesterone does not affect the hypothalamic pituitary axis in a negative way, which is the axis through which your adrenal production of cortisol is regulated, whereas medroxyprogesterone acetate suppresses this axis. P4 is also slightly androgenic, so because it inhibits alpha reductase, 5-alpha reductase. And what we will often see is as women's hormone levels start dropping in their late 40s and early 50s, suddenly overnight they've got these big hormonal breakouts on their chins and on the T line of the face, and that is because the follicles in the skin are now more receptive to testosterone and dihydrotestosterone, and that's why they get this hormonal acne. And the progesterone has got a blocking effect on the 5-alpha reductase, which is what converts testosterone to dihydrotestosterone. So if you can inhibit that enzyme with the natural progesterone, you can create a reduction in the hormonal acne for these women. It's also interesting to know that progesterone improves bone density in and of itself. Well, I don't think we have a lot of clinical studies about that, but we know that its effect is on osteoblast activities. So we know that the cells that lay down new bone are stimulated through progesterone. And then what you must also remember is that often just progesterone can treat early menopausal vasomotor symptoms. It has the ability of modulating hot flushes on its own without estrogen. So the synthetic progestins, like I said to you, they activate the glucocorticoid and the androgen receptors. So we see with these patients that they often gain weight, central weight gain, almost like a pseudo-Cushing's type syndrome. They also struggle with depression, and we also see acne breakout and anxiety with patients on synthetic progestins. So just remember that even though they also inhibit the lining of the uterus, they do not behave the way a natural progesterone would behave in the body. So we will see salt and water retention, bloating. We'll see the increased breast cancer risk, which is across the class. We can see acne, hirsutism, weight gain, and the lipid profiles will deteriorate. Okay, so now we just get to the last section, testosterone replacement. So in South Africa, I'm going to say that there's no adequate transdermal registered product available. And I know that maybe this would be a contentious statement. There is a transdermal product on the market that you can get at the pharmacy, but it is approved mainly for males, and it's a little sachet. It's called Androgel. And if this is the only thing that you can access for women, then you can, but very carefully. And I think your patient intellect level needs to be good enough to understand what they need to do, because I know that in my city, some gynecologists would rather use that than the compounded version, which comes in at lower doses because they've been told not to use compounded hormones. But then the women have to tear off a little corner of the sachet that has got a huge amount. It's got about 50 milligrams of testosterone in that sachet, which is a massive amount. And men are supposed to either use half of the sachet or a whole sachet at a time, usually half of it, depending on how you want to dose it. But women needs a 10th or a 20th of the dose. So the only way you can safely use it is to use insulin syringe, and to get them to suction up a little bit of it, and then apply that. And I have seen women who get lazy and they squeeze out too much on this day and too little on the next day, and some of them have developed clitoromegaly. So I don't think it's an adequate product for women, even though it's recommended as such. A lot of the randomized controlled data that we have on testosterone is done on pellet implants. And again, the guidelines that I'm going to go through, they completely disregard the pellet research because they don't approve of the supraphysiological doses that you get with a pellet. So a pellet is also made up at the compounder pharmacy. It's a slow release tablet that you actually implant under the skin with a trocar. And women come in every 2 to 3 months and sometimes every 6 months, depending on the formulation, how fast it deteriorates and leaves the bloodstream or breaks down. So the gynecology associations are not recommending using pellets because of obviously just soon after the implant, similar to the testosterone injections that the men get, they get a big supraphysiological boost and then a slow decline again. So it's not a nice steady exposure. So the NICE guidelines from the UK have just recently been updated, and I'm going to just show you what they're recommending for women, because up until 2014, testosterone replacement for women wasn't really supported or recommended. So what Jackie said in the beginning, what people don't realize is if you convert on your blood test, if you convert the units that testosterone is reported in to the units that estrogen is reported in, that they are in the same units, you will see that women have 10 times as much testosterone in their systems compared to estrogen. So it's definitely the most abundant molecule in the system and incredibly important. And I'm really grateful that we now have guidelines that approve our using this in women. So this is the International Menopause Society consensus statement on testosterone that was published in 2020. And you see there at the bottom, all the various societies worldwide have endorsed the statement. So I feel very confident to also work within these guidelines. What this guidelines basically said, it's especially indicated for women with sexual interest arousal disorder. The guidelines contradicts itself a little bit because they looked at all the different ways of testing the blood levels for testosterone and come to the conclusion that you can't trust any of them. But then, a few paragraphs lower, when they say you can use testosterone, they recommend that you do use a blood measurement as a baseline and a follow-up. So I'm not too sure how come that contradiction was allowed to go through. So the International Menopause Society recommends that you use the total testosterone. They feel that that's more accurate than the free androgen index, while other guidelines that I've seen prefer to use the free androgen index. So the total testosterone level is basically all of the testosterone in the system, the free plus bound fraction. And we remember now that bound testosterone is not bioactive, it's the free testosterone that's actually available that give us the effect. So it's actually more correct to find out what our free level is doing in terms of clinical response. But again, there's differences in the lab test. The free androgen index is when you are able to calculate out the sex hormone binding globulin part, which is the binding protein, and then you can have a percentage that is left, and they basically say a percentage less than 1% on that calculation, and you can replace testosterone. It is suggested that it is safe in the short term post breast cancer, and it does not change your cholesterol level, your HbA1c, sorry, I made a typing mistake there, or your venous thrombus embolus risk. So you can safely recommend it. You can even recommend it for that breast cancer patient who's now maybe a little bit osteoporotic and you want to give something. Testosterone therapy might be an option for her. What's also interesting is that I've seen some studies that were not included in the guidelines, but some preliminary studies that have shown that testosterone also improves vaginal dryness for breast cancer patients who can't use estrogen. So I thought that was quite interesting. And definitely, again, testosterone is the space to watch. There's also all sorts of studies running in terms of breast cancer prevention with testosterone. Again, we are advised not to use the compounded hormones, but I've explained to you the problems with that recommendation. So I did mention to you that the British Medical Society suggests that we use the free androgen index and that it needs to be less than 1% to indicate treatment. They also recommend that it can take several weeks to reach clinical effects, and you should have a low threshold to quit if a woman doesn't feel better. So if she's not better by 6 months of treatment, you shouldn't feel bad to quit. The British Medical Society also suggests that you should first manage the patient with estrogen and progesterone, first correct the estrogen and progesterone imbalances, and only then, if the testosterone hasn't recovered, then introduce it. And I would actually agree with that, because if you look at the steroid hormone cascade, progesterone is actually what supports our adrenals the most of all of these ovarian type hormones. Out of progesterone, cortisol is synthesized, and if that pathway is nicely supported, then the DHEA testosterone pathway can recover in a burnt out postmenopausal woman. So often all she needs is a bit of progesterone in order for her testosterone levels to recover. There is a very nice article that's also open access called "Should We Be Prescribing Testosterone to Perimenopausal and Menopausal Women? A Guide to Prescribing Testosterone for Women in Primary Care" by the British Journal of General Practice. And like I said, it's open access, and it's a lovely short little article that summarizes most of these recommendations. Here are 2 boxes from this article, talking about the various products that's available. In the UK, it's called Testo Gel. In South Africa, we've got Androgel. I don't know what's available in your country. If you have access to bioidenticals, but not to any of the registered products, the guidelines do say that you can use the bioidentical in that context. What I normally start women on is 1.25 milligrams per ml bioidentical, and then I will titrate up either to 2.5 milligrams per ml or even 5 milligrams per ml. I tend to go in low and go up slowly with testosterone, because I know my estrogen and my progesterone is going to start kicking in at some point. So your calculation of the free androgen index is there for you to refer to. And then they recommend that you keep the free androgen index to just less than 5% for the duration of treatment. So in summary, bioidentical hormones and hormone replacement therapy is a safe and effective therapy. Route of administration matters. It's an individual issue. Fear of cancer should not be a reason to avoid hormone replacement therapy. Hormone replacement therapy helps women live longer and healthier lives, and testosterone replacement therapy should be considered as part of menopausal hormone treatment where indicated. And I thank you very much for your time.
Thank you, Erika. That was absolutely brilliant. I like your last slide. Erika, I wanted to make a couple of comments. I worked in Australia for a while with a guy called Professor Stephen Burrell, who was the head of the breast unit, and he was a very good breast surgeon, but he also had a PhD in molecular oncology. He looked at all his slides, he looked at all his own mammograms, and he really gave a holistic care for breast cancer. So he made a couple of very, very important points. The first thing is that the sex hormone binding globulin is like a bus traveling around and round and round in the circulation. And hormones get on the bus and they get off the bus. So if you've got a ring road around your city, which I think Johannesburg does, Cape Town doesn't really, Harare's got half a ring road, then the idea is the bus is going round and round and round in a circle, but people need to get off the bus to go off onto the flyover, onto where they need to go. And so the hormones need to get off the bus to go to where they need it. Now, if you've got a little bus and everybody's hanging on by their fingernails, you know, they're much more likely to get off. But if you've got a huge bus with 10 people on board, they don't get off. So when SHBG is high, then you may get a high total hormone level, but none of those hormones are bioavailable.
100%.
And something that's very important to understand is that synthetic hormones drive up the SHBG.
100%, especially the oral estrogen.
Yeah, particularly oral estrogens. And then on the bus climbs thyroid hormone and a few others. So a high SHBG is a marker of, and a relatively affordable marker of low hormones in all other areas.
Yes.
So Prof. Burrell was very, very, I had a breast lump when my youngest was 9, which would have been about 2013, I suppose. And the first thing they did was stop my Yaz, because they just said your SHB, sex hormone binding globulin, is very high, and this is contributing to low free testosterone. I then got a testosterone implant with an aromatase inhibitor to prevent the conversion of testosterone to estrogen. And within a week, I was sleeping. I was no longer grumpy. I had all my energy back. My joints weren't sore, and I picked up the phone to Prof. Burrell's wife, who was running the sort of more psychological side, particularly in palliative care. And I said, Shelley, and she burst out laughing, and she said, I was waiting for you to call. And I then put a whole bunch of patients onto testosterone pellets and got them off there and got them onto bi-east creams, and particularly if they weren't sleeping, bioidentical progesterone at a dose of 200 milligrams at night. And I can't tell you how many women's lives were turned around. Another thing that is not a well-known fact is that a low testosterone results in a Th1, Th2 immunity shift. So my rheumatoid arthritis patients got better, my lupus patients got better, and I phoned Shelley again, and she laughed again and sent me a paper. So this hasn't really made it out onto the mainstream media, I think because potentially it's a threat to the synthetic hormone industry, if they actually know that this happens. So the other thing that Prof taught me was about ratios. So we're born as women, we get to 20 and we've got lots of testosterone and estrogen and progesterone, and we get to about 35 and testosterone starts to drop. And when the estrogen testosterone ratio is high, estrogen dominance, one of the first markers of that is poor sleep maintenance. So women start to wake up at 4, 5 o'clock in the morning, and they can't go back to sleep. And as it gets worse, they start to wake up at 1 o'clock in the morning and they can't go back to sleep. And if they get up, they're going to wake up the whole household. So they go to the GP and they end up on benzos, and then they get withdrawal anxiety, and then they end up on SSRIs, and we all know the route that that ends up in. So I think one of the things, if a woman is presenting with poor sleep maintenance, the most testosterone receptors in the body are in the brain. And people must be very cognizant that poor sleep maintenance, fatigue, anhedonia, low mood, check the woman's free testosterone. And the other thing that's worth mentioning is when cortisol is very high, you will get a pregnenolone steal. and then the pregnenolone isn't made into DHEA, which isn't made into testosterone. So a lot of people who've had a big shock will have a lot of cortisol coursing around, and then testosterone drops. And that can trigger quite severe insomnia. So a couple of little pearls from along the way, from what I've learned. A bit later, when you get to about 40, progesterone starts to drop. So now you've got a high estrogen progesterone ratio. And when that starts, you're going to have all your gynae symptoms, which is heavy periods with clots, shorter periods that are 3 weeks. You don't ovulate every cycle. So all of a sudden, some cycles...
You want to stick a fork in your husband's eye.
You don't make any decisions 3 days before you are expecting to bleed. And so people must understand that it's a lot to do about ratios. So when the hot flushes start, estrogen is dropped. But that woman, since the age of 35 all the way through to 50, might actually have had poor sleep maintenance, stress, low motivation, low energy, severe PMT, severe menorrhagia, and in actual fact, people say that perimenopausal women are difficult to be around, but they have no understanding of what on earth has happened to them. And we as a profession have the responsibility to understand this time of life and to manage it accordingly, because testosterone replacement between 35 and 40 in a highly stressed business executive could change her life. And managing with progesterone in an estrogen dominant situation can turn someone's menorrhagia into something manageable, and they don't have a hysterectomy. Because when you do a hysterectomy and you disturb the ovarian circulation, then you've also got a whole new can of worms that you can open. So I think it's just so important that female GPs, because we're the ones generally that are interested, really treat the period from 35 to 60 with the understanding of what happens with the ratios. Because it's not about the absolutes, it's about the ratios.
The researcher that has influenced me greatly in the wonders of progesterone is a Canadian researcher by the name of Geraldine Pryor. There's quite a number of her articles also available on open access, and she has done a lot of work on the perimenopause, and the perimenopause actually starts 7 years before you go into menopause. There's an early and a late stage to it. And in the late menopause, the hallmarks of it is these massive estrogen spikes and then troughs. So women really can cycle through PMS, sore breasts, heavy periods, down into hot flushes, dryness, back into having heavy periods in the last few years or months before their periods completely stop. And what happens is they go and see their gynecologists in the moment and they get put on estrogen, which is a really bad decision, because when there's an estrogen surge, the estrogen, exogenous estrogen and the endogenous estrogen add up, and you now have a stark raving mad woman who is feeling terrible. It's much, much better to go in with progesterone, because progesterone will counter the estrogen surge. It will balance it. And where you have a trough, the progesterone has the ability of partially treating up to 80% of those hot flushes and dryness that you get when there's a trough. So that's why in the perimenopause, like you say, progesterone, very important.
Progesterone and testosterone, critical in the perimenopause, depending on what the symptom profiling is and what the blood testing shows. The last comment I'd like to make is on transdermal estrogen. And the one thing that you might have said, and I might have missed it, is that transdermal estrogens are not associated with deep vein thrombosis.
Yes, I said oral is associated, but I didn't say transdermal isn't.
So I just think it's a useful thing. I've had a patient who recently was incapacitated by Ramsay-Hunt syndrome with very poor balance, and we stopped her HRT, and then she really felt bad. But I basically managed to access transdermal estrogens, which settled down all the hot flushing and everything else. Because with Ramsay-Hunt, you've got pain and you're spinning and you're deaf and you've got a rash and you've got a facial nerve paralysis. And the last thing you need is having hot sweats and you're scared enough without becoming even more irrational. So transdermal estrogen Femigel in this case helped enormously in this patient. And I think we must remember that in our high-risk DVT patients, when patients go into for surgery, for hip replacement surgery, when they're immobilized for any reason, the ideal is to switch to transdermal estrogens if they aren't on them already, and if they want to go back to oral estrogens, because not everybody likes transdermal preparations. Transdermal makes an incredible amount more sense because it's going to be absorbed into the circulation, and its next destination is going to be the right atrium, the right ventricle, the pulmonary circulation, left atrium, left ventricle, systemic circulation. Whereas oral estrogens go to the liver, and the liver goes, oh, I think I'll break somewhere between 20 and 60% of this down, depending on what else it's got to deal with on the day. So I think oral estrogens, there's a lot of pharmacogenetics around how well the serum levels are after you've swallowed an oral estrogen, whereas I think the pharmacokinetics of transdermal estrogens are a lot more stable. And also you have to give a lot less because you're not dealing with the hepatic bi or the hepatic first effect. So I'm a big fan of transdermal estrogens, and I'm a big fan of E2 and E3 in combination. And I've told a lot of patients in my time in Australia that I can guarantee them that transdermal E2, E3 combinations associated with cancer, and they are not associated with DVT. And I think that's a message that has to go across very strongly, and that the reason to use oral progesterone and transdermal testosterone is to improve their sleep, their well-being, and their mood. And if you can get the balance right, you can completely transform someone's life, and you can often save their marriage and their children's mentality as well, because divorce never does any good for any families. And sometimes people's divorces are a lot more related to medical mismanagement around the
I couldn't
menopause.
agree with you more, 100%.
So with that, I will open the floor to questions. Thank you very much, Erika. And we will bring people on to answer questions. People can raise their hands, or we can have questions in the chat. So thank you, Erika, once again for a brilliant presentation. Right, thank you, everyone. That was a pre-recording, and I'm sorry it ran over time. Can you please mute your microphones? Thank you. So one of the questions that is in the chat, Erika has load shedding, so it is very lucky that we pre-recorded this. And Erika, can you come on and unmute yourself?
Yes, hello.
Excellent. In the dark. So
Yes, sorry.
no, it's fine. One of the questions is any particular progesterone we should give to the perimenopausal woman with a hot flash and menorrhagia, and in what doses? Does that also help with the excessive sweating?
So with a patient like that, if she is having hot flashes, I think it's important to look at the FSH level. I mean, if she's still having periods, she's saying menorrhagia, then she's probably not in full menopause yet. So I always start with progesterone. I always try and start with utrogestan if I can. And the standard dose to start with is 100 milligrams at night. You can give it orally or you can give it vaginally. But the utrogestan also comes in at 200 milligrams. So if you can't get control of the bleeding with 100, you can actually go up to 200. And I would really just see how much that does for hot flashes before I move on to adding in estrogen. I would give it a few weeks.
Great. Thanks very much. There have also been a couple of questions in the chat, and I'm very conscious of time. Everybody who wants a recording of this, it will be circulated probably tomorrow on the Intellectus Campus group, and on the SADC group, sorry. And Pride will do that tomorrow. The other question is, when it comes to the age of commencing HRT, I know the guidelines say it's not safe to commence after 60. I'm not convinced of that. I think a lot of women who were denied HRT with the Women's Health Initiative could probably very safely start transdermal estrogens and progesterone 200 milligrams at night at any age. Would you agree?
My chat, what if I go? Yeah, it's going out.
Mute. Mangeli, please mute.
Yes, I do agree with that, Jackie. I think what I think that maybe got lost in that first slide is also that it is recommended to start estrogen late after the guidelines say so. If you, for example, have a situation of osteoporosis. So I do think that you need to look at your patient and look at her risk factors. A lot of people come and see you sort of outside of the window, and they've just found out that somebody's been diagnosed with dementia, or they're finding that they're really struggling still with hot flushes that never went away. I do think you need to evaluate each case individually. I always start with progesterone in cases like that. So I have older women in the practice who we didn't go on to adding in an estrogen. We just have them on a progesterone, and it's great. It protects their brains and it protects them from, decline. And I think given the new data on the safety around cancer risk, I also wouldn't hesitate to add maybe a low dose of estrogen. They do say that there is the reason it's cut off at 60 is because of the cardiovascular risk that some studies have shown. And so if you do initiate somebody, you've got to start quite low and be quite careful.
Okay,
and
thanks
again,
for
it
that.
might have been oral. It might have been oral, in those studies.
Okay. One of the other questions is, what about the Mirena for progesterone? And I think one of the answers to that is the Mirena may be useful for menorrhagia. But the basically psychological effects of bioidentical progesterone are one of the reasons why they're given. But I'd like to hear your opinion on the Mirena in someone who's got menorrhagia.
Yes. So I would speak to the patient. It depends on the scenario.
I would speak to the
It depends on the scenario. So if a patient if the menorrhagia is not severe, I would first try with the progesterone combination, try and control it like that, and maybe also work with the rest of the total picture of the person. But sometimes you don't get control. Sometimes it's really severe, then something needs to be done. So some women go for Mirena. Some women actually get offered an ablation at that time, and in severe cases they do a hysterectomy. But I've never had a problem with progesterone. That normally sorts it out very, very quickly. The Mirena is used. I know the gynecologists love it because of the heavy periods in the perimenopause, and they like to tell the women, just keep it in and we'll give you the Femijol over it. And the thing about that is that you're robbing her from the opportunity of having the natural progesterone and everything that offers, because the Mirena will have this wonderful effect on opposing the estrogen in the womb, but it's not going to give us that wonderful neuroplasticity and the GABA-like effect in the brain. And what about the receptors in the cardiovascular system and in the bone? So you're not improving her health, can I say, with the Mirena. You're just actually managing her symptoms. And then the other problem with the Mirena, that new data that just came out end of last year, is that if you leave it in past the date, so past 5 years, there is biofilm that starts growing on there, and they have started culturing some quite bad bugs that can make a person quite ill. I think it's a actinomyces, that overgrowth that they tend to get. So that is definitely something to bear in mind. And then also remember that it is a synthetic progestin that's in the Mirena again, so coming with all the more negative effects. So again, if you've got nothing else, then that's what you've got to do. Then that's much better than giving an oral synthetic progestin, I would say.
I agree 100%. And I think one of the other things that's important to say, because the question is, what is the risk of breast cancer? We know that the hormones in the Mirena are absorbed for 6 to 8 weeks. And we know that MPA and synthetic progestins are associated with breast cancer. So I personally would be uncomfortable giving a breast cancer risk patient a Mirena if the other option was bioidentical progesterone. But I'm going to have to stop there because I'm getting flack from my Namibian and time controlling, which is very good, people. We still have 156 people on the call, which is testimony to how good your talk is. And we are coming up to an hour and a half. So I think the solution is to get you to talk on this again. What we've done in the past is we've just had the question and answer session as a single event, and we can do that as well if there's demand. So let me know on the group if people just want question and answers, and we can get you back, Erika, in about a month's time. I really hope that we are successful getting you registered in Zim on a philanthropic visa or philanthropic registration to come and teach us integrative medicine. And it's been wonderful to have you on the call, and the comments that have come through have been amazing. And as always, thank you.
Thank you, Jackie. That was wonderful. I really appreciate